Professor Simon Eckermann from the University of Wollongong. And this one is about optimizing net clinical and economic benefits from medicinal cannabis programs. Quality controlled domestication production is key. Professor Simon Eckermann is a Senior Professor of Health Economics at the Australian Health Services Research Institute, the Australian Health Services Research Institute and the University of Wollongong. He was previously Health Economics Professor at Flinders University Centre for Clinical Change and Healthcare Research and Senior Health Economist at the NHMRC Clinical Trial Centre. His original research and collaborations has established missing links between optimal decision-making in research, reimbursement and regulation in practice, and is extensively published in the highest impact international health economics and design making with his original methods research, and clinical and policy journals with his applied research. Ladies and gentlemen, it gives me great pleasure to welcome Professor Simon Eckermann.
Thanks very much, and thanks a lot to United in Compassion for bringing me in the last couple of months in this. Is that?
You're too tall.
I'm too tall. All right. Can people hear me now? Is that better? I'm going to be talking today about optimising net clinical benefit, but also optimising net benefit, which is extending the notion of net clinical benefit to allow for the resource use and costs of medicinal cannabis relative to the types of alternative therapies that it may be replacing. And in doing that, I'll be talking a lot about the optimisation particularly in palliative care and in pain management. I'm going to focus on those two because obviously I haven't got a lot of time, but also health economists tend to focus in on a distinct population. One of the other reasons I'm doing that is I've been involved for the last 12 years in the biggest palliative care trials in the world. The National Palliative Care Collaborative in Australia has now reported on most of those trials, and particularly in pain management with ketamine, and you'll see some slides on that. And that's going to be particularly key because we're going to show that the cannabinoids are far more effective than most of our current therapies in a palliative population. And we're also going to show that the palliative population is going to be increasing immensely with the ageing of baby boomers, and something that I'll refer to as gerontolescence, which is successful ageing. So that's pretty much a picture of where we're going to go. As a health economist, I always have to address the question of, well, how can health economists help? How can we aid in any of these decision-making processes? And in general, health economics considers related research, reimbursement and regulatory decisions. And it does that across the health, but also wider system, including the aged care system and other parts of the social system. And indeed also across the political economy. And I think that's a particularly key issue in this area as it is in palliative care. And I particularly think that's important because what we're really looking at here is the respect and representation of community preferences rather than those of other vested interests, and particularly drug companies and profit-making interests. So health economics also looks at the incentives of agents, both the providers and the institutions, in trying to align with those community preferences. And I'll be doing a bit of that at the end. The underlying objective that health economists always look at, and we synthesise a lot of evidence. We synthesise randomised control trials, epidemiological evidence, and evidence about the community preferences. But the overall objective is to maximise net benefit. And we do that ideally across joint government investment, research and regulatory decisions. And this is a very typical example that we're looking at here with medicinal cannabis, where those things are inextricably linked. The research question, the regulatory decisions and the reimbursement questions. So just to give you a bit more background on that, maximising net benefit, the way it's normally done is kind of represented in that schematic there. And we normally are looking at some sort of evidence that we get from the literature around individual randomised control trials or systematic reviews of evidence, and that gives us a notion of a relative treatment effect. But in any setting that we want to apply that to, we're going to modify that by the baseline risk or epidemiological risk in that population. And this relative treatment effect, of course, is going to be relative to the alternative therapies. So in the case of cannabis and the pain management we're looking at opioid therapies, ketamine, etc. we can then get an estimate of what the absolute effect difference is, and you can do that for both harms and benefits and for side effects. And the important concept here is we get coverage. We get coverage of both the primary effects but also secondary effects and side effects, and combine those to get an estimate of what net clinical benefit is, which is what clinicians do a lot of. They're trying to say, for my patient, what is the best therapy given their profile, their risk factors, the benefits they might have given their symptoms, etc. All we do to extend this notion of net clinical benefit to net benefit is add in the resource use and cost implications of the therapy relative to the alternatives. So this is the incremental effect, if you like, and here we're adding in the incremental costs. So it's the value of the incremental cost, value of the incremental effects less the incremental cost, which is net benefit. And that's the overall objective. So for a societal or policy decision maker, we're trying to maximise net benefit given the net clinical benefit, but also given the resource use and cost implications. So let's have a look at some of this in cannabis, and particularly, as I'm going to talk about, in palliative care and chronic disease. So I'm going to take you back to the 1960s and to when many people probably had their first experience of cannabis, etc., and particularly the baby boomers. Because the baby boomers are going to be very key in the acceptance and use of cannabis in older age particularly. But in the 1960s, the science was fairly raw then in terms of cannabis. We didn't really know about the therapeutic benefits of cannabis. But since then, and largely from those Israeli researchers and several others internationally, we've discovered the potential of the endocannabinoid system, and that was particularly in the late 80s and early 90s, and the role of CB1 and CB2 receptors. Since those 1990s, we've shown, and indeed even before then, without that knowledge, we've shown advantages of a variety of medicinal cannabis therapies with different THC and CBD concentrations, and with a whole series of smoking and non-smoking modalities. And the important thing is that they bind with the receptors in treating a range of chronic diseases and palliative care populations. So those trials which have been undertaken really since 1975. It's really since the 1990s and the discovery of the endocannabinoid system and the receptors that we've had a larger proliferation of trials and quite a bit of evidence. We've obviously also had many thousands of years of evidence of epidemiological use. When we look at the net clinical benefit, we're looking at that for various combinations and concentrations or doses of THC and CBD, but also the fuller spectrum synergies and entourage effects with endocannabinoids, terpenes, and a whole series of things that we've been talking about, particularly yesterday. And we want to customise those for the tolerance and patient needs, and particularly the modes of administration in terms of the patient needs, and obviously night versus day, particularly with regard to how much THC, etc. And those things have been and are continuing to be established just in time for what I'm going to be calling the baby boomer gerontolescence. And that term I've stolen from Alexandra Kalash, who is the sort of ageing guru in the world. He was director of World Health Organization for 20 years, set up 1,800 age-friendly cities and indeed dementia-friendly cities as well. But I think it's a very good concept, gerontolescence, because it's talking about successful aging. And I think cannabis has a big part to play in successful aging, but also in palliative populations. And in the next slide, I'm going to show you how important that's going to be for Australia. So the baby boomers are the people born in 1946 to 1964, and the oldest of those are currently 70, and the tail end of those, the youngest of those, are now 52. They'll be reaching 65 in 2029. So it's really from 2011 to 2050 that Australia, and indeed the world, face the challenge of the baby boomer ageing revolution. And we go to the, there's a lovely little ABS link there, which hopefully will come up, where I can show you the impact of the baby boomer ageing. So baby boomers, in general, you can see there in the words there, the sort of profile they're in now. They're 52 to 70. As we move forward, and you'll see this in this diagram there, There we go. That's now, in 2015, the age profile for males and females. And the baby boomers really start... don't move it yet, I just want to... they start at age 70 now, and they go down to kind of age 52. So you can see those two, what you might call love handles, on the sides there, which show the proportion of the population who are between 52 and 70, and there's little things coming out. That's where we had a lot of births, and the baby boomers are. As we go forward, and if you go forward now, you can see that the proportion of those entering old age increases and increases, and most importantly, the proportion over 65 and over 85, as we head towards 2050, becomes very large indeed. So we're going to double the proportion of our population over 65 and quadruple the proportion over 85. And those schematics, what we're doing there on the bottom is we're going from 2015 to 2050. And that's pretty key because that means there's going to be a huge chronic disease population and a huge palliative population. We're going to be quadrupling in terms of the estimates what our palliative population is, and probably tripling the chronic disease population over the age of 60. Let's go back to the slides now. So the gerontolescence or ageing revolution reflected in those life expectancies, and indeed the life expectancy is now 22 years for a woman who's aged 65, so they're going to get to 85 on average, and indeed also for males. And that is going to lead to a whole series of explosions in the populations who have dementia, the populations who have chronic disease, and the populations who we need to be undertaking palliative care with. Whoop. So, in palliative care, which is going to focus most of my efforts, we've got controlled trial evidence since 1975, and there's a couple of very nice meta-analysis type summaries of that in Grothamham 2012 and the IACM in 2011, which show a lot of the trials which are undertaken. And it's in many areas. I'm going to be focusing on the chronic pain and cancer ones particularly. And they've shown a whole series of advantages in chronic pain management for cancer, rheumatism and fibromyalgia, neuropathic pain and sleep and multiple sclerosis, nausea and vomiting, etc. And you've seen a lot of those over the last couple of days. The one I'm going to focus on is the intractable pain one, because that's the one where 90% of the people in the US have some form of pain that they're being treated for with cannabinoids, and it's also the one which is of most interest to the palliative population. So in intractable cancer and palliative pain, there's a lovely trial which was undertaken by Johnson et al. In 2010, and that's of oral therapies, and it was a 3-arm trial. They had THC to CBD 1-to-1, they had placebo, and they had straight THC. I've been reliably informed by Russo yesterday that in fact the THC to CBD extract also had terpenes and also had flavonoids and various other endocannabinoids in it. The important thing is it's far more full spectrum than the THC alone was, and we have placebo in there as well as an arm. So in those populations, the evidence from the trial is that you get double the proportion of patients with the THC to CBD extract having a significant response in terms of pain relief, while no difference in opioid use or rescue medication. So it's not influencing the amount of rescue medication of opioid use you get, but it's giving us double the pain relief, which is huge in terms of therapies out there. And indeed, the only other real therapy out there in these intractable cancer and palliative pain populations is ketamine. And I was involved in the largest palliative care trial in the world, which is reported on the bottom there, which showed there was no benefit at all of ketamine for pain relief in palliative populations. Okay? And it's a finding which has stunned many because there'd never been a adequate placebo trial until that 2012 study. And more than that, it also had dangerous side effects and in high levels of death, etc. And it also didn't reduce opioids or rescue medication. So the important thing is cannabis, if we compare it to the best comparator at the moment in palliative care, ketamine, clearly has much greater effect and without the side effect profile that ketamine has. So in terms of net clinical benefit, Mather noted in the Medical Journal of Australia that the benefits of cannabinoid pharmacotherapy can be substantial, the risks are generally modest and must be weighed against those of not treating the symptoms or of alternative treatments. Well, we've shown relative to alternative treatments it's got much greater pain relief and it doesn't have the side effect profile, and that's very clear from randomised controlled trial evidence already. But the other thing I really want to emphasise, apart from just the extra pain relief, is really this issue of the gerontolescence, successful ageing. Because in these palliative populations, what they're actually interested in is not survival, it's not quality of life. What they're interested in primarily, and we've done extensive research to show this in the Palliative Care Collaborative, is firstly finalising their personal and financial affairs. And the financial affairs is normally about not leaving a mess for their kids, basically. Secondly, they want to be normally at home or in the community of choice to undertake their palliative care. Thirdly, they worry about the distress of carers and family. And then, finally, fourth line, they worry about their quality of life, and fifth line, their survival. So that's the preferences of palliative care patients. And they're not supported, those preferences, by the current therapies, the medicalised type therapies we currently get them, and particularly chemotherapy, radiotherapy, which when you think about it, draw you away from home, give you side effects which compromise your ability to finalise affairs, and cause incredible distress to families and carers more generally. And they're incredibly expensive. So it's really in those type of settings as well that obviously cannabinoid therapies, which have this ability to have pain relief but also a whole series of other things, nausea, sleep, etc., which is the other symptoms cancer patients face, could be a very cheap option, which allow you, more importantly, to stay at home, be with your family, and undertake the finalisation of those affairs, etc. The primary things that palliative care patients are interested in. So palliative preferences in general support at-home care with greater family and care involvement, and cannabinoid therapies provide a mechanism for doing that, and at much lower cost than many of the medicalised therapies we currently have. So the only side effects really that have been noted in the literature are tiredness and dizziness, dry mouth, and potential psychological effects. But obviously that depends on the amount of THC, etc. And they're less severe than alternative therapy. So even where there are side effects, the alternative therapies we're talking about here in palliative populations, much less in cannabinoid therapies than they are with those palliative other therapies that are out there, the ketamines and indeed the opioids. And we find, of course, that tolerance to all of these side effects normally develops also with cannabinoid therapies, and indeed we're customising to avoid those side effects in the way cannabinoid therapies are used. So alongside the evidence of better symptom control, you can also avoid many of the side effects of typical alternative opioid therapies, or the side effects of palliative radiotherapy particularly. And those are things which are particularly valuable to palliative patients, because those are the things which prevent them from finalising their affairs at home and in their community of choice, which is their primary objective. So customised use of cannabinoids, selection of plant strains and component synergies have great potential for common palliative care, late-stage cancer, chronic disease symptoms, and particularly in pain. And there's a quote there from De Bruin for that. So let's have a look at ways that medical cannabis programs have been used, and this is really old hat for all of you. So we know they emerged in '96 in California, and they've now got greater than 1 million registered users, and 90% of those who are treated have severe pain. 70% it's their primary, but 90% either primary or secondary. So in Australia, obviously, we've legislated to enable cultivation of cannabis for medical and scientific purposes, with New South Wales trials notionally occurring now, and Victorian medical programs from 2017. The key things in terms of what we can learn, I think, don't actually come necessarily from the States, but from Italy. And in Italy, they've set up secure outdoor facilities for medicinal cannabis, and that's because they have ideal outdoor growing conditions, but pretty much the same growing conditions as Australia. Eucalypts grow in Italy and they grow in Australia for very similar reasons. They have a kind of Mediterranean climate, not unlike that of South Australia. So like Italy, Australia can grow outdoors at much lower cost, a fraction of the cost of hydroponic or indoor growing, which is basically what the Dutch, UK, and indeed most of North America face, apart from certain parts of North America, and particularly Canada, the comparator that we were shown yesterday, where they don't have the climate or the conditions to grow it outdoors. The other really key thing, apart from this lovely cost advantage you get from growing it outdoors, it can also support key research in optimal strains, because you get the full synergies, you get the full spectrum, and you get much better terpene profiles, etc., from outdoor growth. And of course we can look at modes of administration, etc., because we've got that full spectrum. We've not got the narrow spectrum which we would have if we had drug company, 2 or 3 single active agents being provided to us. So like Israel have done very successfully, you can have a whole proliferation and the toolbox for treating cannabis patients if we go down an outdoor growing route and with full spectrum. And obviously we can look at, as they have in Israel, with different modes of administration, etc. And we should be learning, absolutely, from Israel and sharing our education and research in undertaking that. And sorry, I haven't put the Israel stuff there because I only learned about it 2 hours ago, but I'm sorry about that. So in addition to maximising net clinical benefit, full spectrum medical cannabis, THC and CBD-rich strains, securely grown outdoor as in Italy, offer a low-cost, quality-controlled alternative to current therapies at a fraction of those alternative therapies' costs. The other really key thing is that if we identify the appropriate indications, as they've done in Israel, we can point to public funding given lower costs or better symptom control and lower side effects compared to current therapies which are offered for pain relief, for palliative care, for basically anything we've talked about at the conference though. It's not specific to palliative care, that comment there. And in reality it means you'd save the health system much more than you'd actually would cost, and particularly if we're growing it outdoors at factor prices, which are much lower than the current street price of various products that have been used. So those are the kind of primary benefits, and we should really be looking at PBS listing or some sort of public funded listing of these things, not relying on private, because it's saving the system a lot of money, far more money than it's going to cost them. And I'll go through some of the numbers for that in the next slide. We also get a whole series, that's the primary benefits, we also get a whole series of secondary benefits from regulated, quality controlled and secure outdoor production of cannabis, and those are expected in firstly ensuring quality controlled local access, because at the moment that's not occurring, and undermining organised crime and the high price that we pay because of that, and some uncertainty around the quality in these very vulnerable populations, which is what have been highlighted in the press extensively. We also have, and this has been highlighted by a couple of other people as well, distinct export potential. So we've got the ideal outdoor growing conditions, and they don't in most of Europe, North America, etc. Virtually the whole of Australia can be used, from Tasmania right up into northern Queensland. So we have the outdoor growing conditions for this. We get a whole lot of advantages in terms of net clinical benefit, and then cost advantage as well. Net benefit is much greater if we grow it outdoors. But in terms of export, it gives us a huge comparative advantage. So, advantages of quality controlled full spectrum outdoor productions is like a summary slide. Well, on the effect or benefit side, it ensures supply to better pain management, and we've shown that in the Johnson study, but more generally you could add in a whole series of other indications there. It facilitates research on different therapeutic combinations of strains, so there's THC to CBD ratios, the terpenes, etc., and the synergies and entourage effects those allow, to treat different symptoms, conditions and populations, and cannabinoid profiles in full spectrum versus narrow single phytochemical extracts. So there's a whole lot of advantages for having the full spectrum, as well as being able to potentially use single spectrum or more narrow spectrum phytochemical extracts. And that, most importantly, for the patients and for United in Compassion, enables appropriate customisation to patient tolerance and optimise therapeutic benefit more generally in appropriate indications. And I really want to, I've listed the PBS there on the right, because in reality that's what PBS are interested in. What are the indications? And certainly for public funding, I think that's what should be occurring. We should be looking at the indications for PBS listing or some other form of public listing. PBS also have various other things they run in palliative care, certainly alongside PBS listings. On the cost side, we've got lower production costs than indoor production, and certainly in Europe and North America. And in general terms, the factor cost of output production in Australia is about 1/10 of that compared to the value-based price that they're currently quoting in the US. So it's about $1 per day for a kind of average use of 20 milligrams versus $11 a day that the De Bruin study in the US, commissioned by Deloitte, etc., put forward as the value-based cost. We can get factor pricing if we produce it here outdoors, which is much lower than the value-based price that they currently have in the US. And that's a huge comparative advantage to export. So factor therapy-based pricing would save you about $10 a day Australian for each patient treated, and in the 200,000 pain management treatments alone that would be expected given the kind of same prevalence as in the US, you'd save about $730 million a year currently. Now, importantly, that's going to get much larger as the baby boomer ageing occurs, because that's now. I'm talking about quadrupling probably that, just in terms of the population who are going to be in pain management, etc. So you'd be talking about $3 billion a year by 2050. That's just the direct costs. You also will be saving costs associated with the downstream effects. So having better pain management leads to lower levels of hospitalisation, lower levels of GP use, lower levels of specialist use, etc., and lower aged care facility use. So all those things would also be additional cost savings on top of that. And indeed, that's also associated with the side effect, having much lower side effect profiles, not just the pain management. And then finally, we get the export potential from quality and cost comparative advantages if we grow it outdoors with all these lovely synergies and the entourage effects, etc. So bottom line, and I always do a bottom line one because policymakers are out there and politicians, they want one page. So the bottom line is that outdoor full spectrum production and public funding, you'd save $10 per day directly in pain management alone. Obviously there's a lot of other indications, for 200,000 plus medicinal cannabis chronic pain patients, and that's about $730 a year currently and growing fast with baby boomer ageing. While also maximising that clinical benefit with improved pain management in terms of reduced side effects, but also obviously better effects for symptom management relative to opioids or other therapies, and particularly ketamine, which is the only real alternative in those intractable patients currently, and reduce the downstream treatment costs, which I haven't even quantified, but they would be substantially more, I'd imagine, than $730 million, and certainly in the cancer patients. Thirdly, enable robust research, optimising strains and CBD ratios, etc., full versus narrow spectrum extracts, and mode of administration custom-made for patient response, tolerance, and I think you can talk about the night and day type tolerance, etc. And fourthly, create export scope and ensure quality controlled Australian medicinal supply. And there's a whole series of references there.